The situation that we were trying to address is that on May 1, the Food and Drug Administration made available the drug Remdesivir under an emergency use authorization. It's not yet an approved medication. It's an antiviral, and really the first one found to be efficacious to address COVID-19 by reducing hospitalization length. A mortality benefit was not demonstrated to statistical significance. I'm Susan Wolf. I'm professor of law, medicine, and public policy at the University of Minnesota.
My name is Dr. Sarah Lim with the Minnesota Department of Health, and this article is developing an ethical framework for allocating remdesivir in the COVID-19 pandemic, and will be appearing in Mayo Clinic Proceedings, the September 2020 issue.
And together with Dr. Lim, and we have 10 other co-authors, we're very pleased to produce what's really a breakthrough article on how to do ethics in real time, given emerging and suboptimal evidence, in order to come up with an ethics framework for allocating, in this case, the scarce resource of remdesivir in an evolving pandemic. So the Department of Health and Human Services, the federal HHS, began distributing remdesivir to the state departments of health. Actually, there was a little confusion at the beginning, but ultimately to the state departments of health, which then faced the question how to ethically and appropriately distribute that medication to facilities across the state. So the Minnesota Department of Health faced this issue. Fortunately, Minnesota's Department of Health has a very long history of addressing the ethics of allocation and other issues in the context of a pandemic. They started with work anticipating an influenza pandemic, an H1N1 pandemic, more than 10 years ago, and working with the University of Minnesota and other entities, developed very important guidance. So the Minnesota COVID Ethics Collaborative, MCEC as we call it, is a new group that was formed in March to assist the Department of Health in Minnesota in developing an ethical response to this particular pandemic. That said, it builds on the prior guidance because that prior guidance called for a standing ethics entity, and it also gave real guidance on what ethical principles should guide action to cope with the pandemic. So we've had the benefit of all of that. What we found is that looking across the country, states had extremely disparate responses to the challenge of ethically allocating remdesivir in this pandemic. With help from MCEC and also clinical experts, including some who were already involved in clinical trials of remdesivir, the Minnesota Department of Health was able to evolve a framework that's on the Minnesota Department of Health website. And that framework has evolved. One of our earliest challenges was the lack of solid evidence. The evidence was emerging on what patient populations would really benefit from remdesivir. And in fact, when the Food and Drug Administration emergency use authorization was first issued at the start of May, there was nothing in the peer review literature really to guide that solidly as yet. I mean, there was a document issued with the EUA, but it really wasn't until several weeks later that we saw in print real guidance, and that was even preliminary data. So this is really an account of how to do ethics, public health ethics, and allocation of a scarce and important resource in real time, what we call real-time bioethics, and how to develop a living document. We've had to revise this document repeatedly with the emergence of more evidence, more clinical experience. I'm going to ask Dr. Lim to comment more.
So we think that one of the strengths of our framework has been its flexibility, and that as new evidence has emerged, that the document really has been acting as a living document and has allowed us to refine our prioritization criteria and refine our overall framework more than once as new evidence has emerged, and has also incorporated feedback from clinicians and others implementing it in real time. So we've been able to really understand how it's being implemented on the ground.
Let me add that one of the things we realized in coming up with this framework and looking at what other states were doing is that there's a real need for concerted study across the landscape of allocation frameworks, looking across the full country to catalog these things. There's really no central place where they're kept, and to analyze their implementation and their consequences, their intended consequences and their unintended consequences. Our framework, one of its strengths is, in addition to stating clinical tiers of patients based on who's most at risk and who stands to benefit as best we can glean from the current evidence, we also rule out allocation based on discriminatory grounds. Allocation by race, ethnicity, sex, ability to pay, socioeconomic status, immigration status. But in addition, we call for the collection of data to analyze retrospectively equity, fairness, impacts, clinical impacts, social impacts. And this is an enormous challenge that really ought to be undertaken comparatively and nationally.
I'm just going to add one point to that. The Minnesota Department of Health was really fortunate, not just that there had been all of this prior work that had gone into thinking about allocation of resources during a pandemic, but that there was also an ethics advisory group like MCEC that was already stood up and working on these issues, and that we were able to reach out really in a very short period of time with really minimal notice, and were able to tap into that expertise and that knowledge to be able to develop this framework really quickly. So we think that one of the other key takeaways from this should be that having that type of advisory group sort of ready to go that can start to work on these frameworks in real time is really important, because this pandemic is moving and evolving so quickly, and things are having to be done at really an unprecedented speed.
So some of the resources offered by this article include an online appendix, which reprints in full the allocation framework that the Minnesota Department of Health adopted for Remdesivir in May, and then a link to the current location of the framework, which has been revised successively with the emergence of evidence and experience. In addition, actually, there are a wealth of resources that the Minnesota Department of Health posts. That includes a separate allocation framework that MCEC worked on in collaboration with the Department of Health, and the Department of Health ultimately adopted, on the allocation of ventilators and related scarce critical care resources. So there are numerous ethical and allocation challenges that this pandemic is posing. We think an account of our experience with Remdesivir is going to be useful for other states, both as they think about establishing a standing ethics body to help, as we've got now in Minnesota with MCEC, but also concretely as they think about actual approaches to medications like Remdesivir. We very much appreciated working with Mayo Clinic Proceedings to bring this article rapidly out into the public domain and to press. This entire pandemic is moving so quickly. The need for resources like this is so acute that being able to get this out and get feedback is vital.
Thank you for reading our article, and we really hope that it will be helpful to others who are dealing with some of the same problems that we're dealing with.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.